Similarly, bladder biopsy as a part of initial workup is supported by only few organizations like ISIC and the European Association of Urology. Well, the rest of the organizations throughout the world, they take it to be either optional or they don't recommend it. So why we need a cystoscopy in bladder pain syndrome? We know that cystoscopy has a both diagnostic and a therapeutic value. So if we do a cystoscopy with hydrodistension, we can document the stigmata of bladder pain syndrome like glomerulations and Honor lesions. In the meantime, we can rule out many disease conditions which can present as a bladder pain syndrome like carcinoma in situ, tuberculosis, eosinophilic cystitis, and etc. So we can take a biopsy, we can assess the bladder capacity, which probably will guide to us whether the patients will be benefited by doing a therapeutic hydrodistension or not, although it has got its own limited efficacy. So since the patients will be taking under general or regional anesthesia, it can be an opportunity to ablate the Honor lesion by means of different energy sources. And after all, considering all the findings, gross findings in the cystoscopy and the biopsy, we can make an overall prognosticate the disease in future. So there are certain rules to have a cystoscopy. And we know that the hydrodistension is an essential part of a diagnostic evaluation if you do a cystoscopy. So normally the rigid cystoscopy is preferred over the flexible cystoscopy because of its better optics, ease in taking multiple biopsies, and a good better channel for the irrigation. The patient has to be taken under some form of anesthesia, either a general anesthesia or a regional anesthesia. Local anesthesia is rarely condemned because the patient is already having a pain, and on top of that, if you are distending the bladder, it will be unbearable. So we do not recommend a local anesthesia. The irrigation height has to be maintained at around 80 centimeters from the symphysis pubis, and we have to see the bladder when it is not fully distended, like we do in a regular cystoscopy, when the volume is around 150 to 200 ml for the pre-existing lesions, and especially for the Honor lesion, because once we distend the bladder, the Honor lesion might disappear. And we continue to fill the bladder till the irrigation stops on its own. But we should not exceed the volume by 800 ml or 1 liter, even if it continue to go also. And there are two options. If we are taking the patient only for a diagnostic hydrodistension, the duration of distension should be of around 2 to 3 minutes. But if we are taking the patient for a therapeutic hydrodistension, the duration will be up to 8 to 10 minutes. After it's completely distended, we empty the bladder and note the effluent and collect the amount, also measure the amount, and the amount which is measured gives the maximum capacity of the bladder. And if there is a hematuria, especially in the terminal part of the effluent, that indicates that there are lesions which has bled. And normally the bleeding stops by putting a irrigation catheter overnight. Subsequent distension is not done with the maximum capacity for a better visualization of the lesions as well as there should be also.
Hello. Can somebody please unmute their mic? Somebody who's not a speaker, please unmute. Please mute your mic.
Yes. The lesions, the lesions should be described in a systematic way, and the biopsy should be taken once the hydrodistension is over. We should not take the biopsy in a fully distended bladder or before going for a hydrodistension, because it can lead to a perforation of the bladder. And we need to take at least 3 biopsies from different areas in addition to the biopsy from the lesions. This is how I have picked up from a journal of urology. This is how the documentation has to be made with the diagrams. Now I would like to talk something about the specific lesions like Honor lesion and glomerulations, which we pick up during cystoscopy. The Honor lesion prevalence is 5 to 57%. It's a widely variable because the most important problem in not picking the Honor lesion is due to the lack of experience of the person who does a cystoscopy. And the Honor lesion has got a distinct clinical, pathological, and treatment differences. Like the previous speaker, Dr. Manish also has highlighted that now the trend is towards gradually going towards differentiating a patient from with the Honor lesion versus non-Honor lesion. So Honor lesions, we have to pick up the Honor lesions in the not in the fully distended bladder initially, because once it get fully distended, it might be obscured. These are the few pictures showing the Honor lesions. Like in A and B, we can see the Honor lesion. What is the C picture? In the C, we can see post hydrodistension edematous mucosa, and D is showing the waterfall pattern of the bleeding. Now, glomerations is given so much of emphasis in NIDDK criteria, but glomerations are not so specific to the bladder pain syndrome, because it can simply be a reflection of the rupture of the vessels in a previously underfilled bladder. And it can be detected in various conditions like neoplasia, different forms of cystitis, infective radiation or chemical cystitis, and chronic underfilled bladder. These are the few pictures showing the glomerulations and the typical rainfall pattern of bleeding. Remember that if the Honor lesions it get stressed during hydrodistension, it gives rise to a waterfall pattern of bleeding, means the bleeding is more profuse. But if there is a bleeding from the glomerulations, then it gives rise to a rainfall. That means the sparse. It's not so profuse bleeding. Now, ISIC has given a cystoscopy classification from grade 0 to grade 5, indicating the severity of the disease. Now, after going through the cystoscopy with hydrodistension and biopsy, again, the ISIC has given a subtyping of the bladder pain syndrome. So it indicates, like, if it is a 3C, that means there is a Honor lesion in the cystoscopy, and C represents the severely inflamed nature in biopsy. So it is indicated by the two things. Number represents the cystoscopic finding, whereas the later alphabet represents the biopsy finding. Something about a cystoscopy in therapeutic hydrodistension. uh, it has got a short-term efficacy up to 60%, whereas the efficacy almost becomes zero by the end of 6 months to 1 year. And it is found to be more effective in patients with Honor lesion in small capacity bladder. The possible mechanism of action are basically the degeneration of the efferent nerve endings due to a pressure of the distended bladder. So there are again not the different levels of recommendations, and the overall level of evidence for therapeutic hydrodistension is 3 and recommendation is grade C. Now, something about narrowband imaging cystoscopy, as we know that in other conditions also, like especially in malignancy also, the chances of picking up the pathology by narrowband imaging is far superior as compared to the white light cystoscopy. And so if we use a narrowband cystoscopy, it may avoid the hydrodistension, and we can pick up the lesion in the early phase. These various pictures showing the narrowband imaging images, you can see that. So it can be a better armamentarium as compared to the white light cystoscopy. Finally, there are certain limitations of the cystoscopy, as we know that it is contraindicated in UTI, pregnancy, past history of perforation of the bladder with hydrodistension, and if the patient is of high anesthetic risk. There are certain complications like hematuria, clot retention, urosepsis, bladder rupture, and bladder necrosis, which is a very rare entity. So to come to a conclusion, although cystoscopy is not widely recommended as an initial diagnostic tool, but anyway, it can provide us an objective evidence for the diagnosis, classification, management, and prognosis of bladder pain syndrome. The standardized diagnostic criteria gives a uniformity and comparability of the studies, which can be documented through cystoscopy. And it can, in the meantime, it can rule out the dreadful conditions which might present as a bladder pain syndrome, and which might be treating for a long duration before finally it goes into an advanced stage. With this, I would like to conclude my presentation, and I would like to thank NOWS and GIBS for this opportunity. Thank you.
Thank you, Dr. Ghanshyam, for the extensive elaboration of the cystoscopic finding. During your presentations, I found some comments from Dr. Siva Priyadarshi. So I'll request sir to take this forum for a few minutes and highlight about the Horner ulcers, because this is considered as one of the hallmark of the disease, diagnostic criteria for this disease. So requesting Dr. Siva Priyadarshi to take few minutes highlighting on this topic.
A very good evening to all of you. I compliment and congratulate Dr. Pawan and his team for taking this initiative. And I'm really feel happy that we are working together, both India and Nepal, both societies. As you said, Dr. Ghanshyam was saying about the Horner's lesion. Cystoscopy is one of the most importantly used just to differentiate between a Horner's IC and a non-Horner's IC. And as he said that it should be seen only in a non-distended bladder, and after distension it disappears, which is probably not true. What we see usually is a scar which has a radiating vessels around, that is a Horner's lesion. And when the bladder gets distended, there may be a crack or ulceration in that lesion with subsequent bleeding also sometimes. So it won't disappear, but the lesion would crack or ulcerate. Secondly, as I said sometimes you may not see the stigmata on a non-distended bladder. So a diagnostic hydrodistension is also required in these cases, as he has also mentioned in his talk, to produce these stigmata. So not necessarily that you have to see all these stigmata in a non-distended bladder only, without distension. And the third thing was about the therapeutic hydrodistension. 8 to 10 minutes hydrodistension, most of us would agree now that is not required and may be counterproductive or may be dangerous also in some of these patients. So maximum 3 to 5 minutes hydrodistension is quite enough to produce the result. So that was my take on Horner's lesion and all. Yeah. Thank you.
Thank you, Dr. Sivam. So now we would like to move to the next presentation by Dr. Rajesh Taneja, who is chairman of the GIBS, and I'm sure under his leadership, this particular disease will have lots of treatment options in our region. So because many people will become more aware about these conditions and they will have lots of discussions in the platforms. I'm sure these conditions need to be discussed at least once in our National Congress. So we, in this present context, we'll make sure that these interstitial cystitis, bladder pain syndromes, which they're rampant in our community, need to be discussed during our national meeting as well. So Dr. Rajesh Taneja, please.
Yeah, thank you. Thank you, everybody. And thank you, Dr. Pawan. This has been a wonderful session. And as I said, I'm very happy to see so many people talking about interstitial cystitis and talking so well about it. And they are so well informed. I think my dream of starting this organization has really bore fruit. And that is, you cannot have more joy than this. Anyway, I will start with my presentation. It is a video with an audio background. So this is a brief atlas of cystoscopy, and it starts now.
In bladder pain syndrome, interstitial cystitis, cystoscopy must be done as a comfortable procedure, preferably under general anesthesia. The only definitive diagnostic criterion for BPSIC is presence of Horner's lesions. Non-specific findings commonly encountered are glomerulations, mucosal cracks, draining of blood, Horner's lesions, typically stellate-shaped structures on the distensible part of bladder. Rest of the bladder is usually having normal mucosa except in late, end-stage bladders. The center of the lesion has a stellate shape with linear extensions which appear pale ischemic zone. Capillaries arranged in atypical parallel array seem to be radiating at right angles from this pale area. From a distance they appear to be a patch of erythema. Grayish slough at the summit of the pale stellate area. Are there any stages of Hunner's lesions which corresponds to the phase of progression of disease? This is a typical Hunner's lesion in an early disease where the rest of the bladder is healthy and appears to be compliant and well distensible. This is a little longer standing disease. Note that the lesions are more erythematous and there appears to be tendency for confluence. Another case of early Hunner's lesion. Note that after hydrodistension, draining of blood is occurring only from the center of the Hunner's lesion and nowhere else in the bladder. This is characteristic of early disease. This is a case of 3 years duration. Note the characteristic morphology and multiplicity of Hunner's lesions. Note that one lesion is close to the trigone on right side. The cracking of the pale ischemic central zone upon hydrodistension is clearly visible. After hydrodistension, the lesions are being electroablated using a ball electrode. Long-standing disease with diffuse mucosal edema and small capacity bladder. Hydrodistension and electroablation has been done. Note the central cracking of the lesion upon hydrodistension. The rest of bladder doesn't show any cracking or bleeding. This case depicts non-specific glomerations which are diffusely occupying the distensible part of bladder. Note that this is non-specific finding and is not diagnostic of BPS, IC. This is a long-standing case with rigid subcervicales upon hydrodistension. The presence of typical Hunner's lesion is diagnostic. Note that draining of blood is only from the Hunner's lesion. Long-standing case with multiple Hannah's lesion fibrotic bladder. Note: the appearance of Hannah's lesions and compare them with the early cases depicted before in this video. This is a case of aggressive disease. The Hannah's lesions were treated few weeks ago and the patient had recurrence of symptoms within weeks. The partly healed Hannah's lesions are visible. Note that upon hydrodistension, only the areas with Hannah's lesions bleed while rest of mucosa is simply inflamed. The patient had been treated with hydrodistension and ablation of Hannah's lesions with good response for over 2 years. The cystoscopy was done for relapse of symptoms. Note: the central cracking. The science of BPS IC is evolving. Thank you.
Hello. Hello. I hope the presentation was okay.
Yes, sir. Thank you very much, sir. Thank you, Dr. Rajesh Taneja, for the well-prepared and informative video on the cystoscopic description of interstitial cystitis. The pathology is well described, sir, and it's well characterized. I found it more informative than in any textbook that I read, because the lesion characteristics and everything is described so well. So I think it is treasure that we found the treasure today in this platform. Thank you, Dr. Rajesh. So there might be many questions.
For the
yeah.
Yeah.
So now I will request Dr. Amita Jain to present on the treatment aspect of this disease. And I will also request Dr. Rajesh to moderate the case-based discussion and the question answer session. After this presentation, we are going to have a small 10-15 minutes question answer sessions. So all the panelists will be involved, and I'll request Dr. Rajesh to take over from me and continue the program. Thank you. Dr. Amita, it's to you.
So can you see my slides?
Yes, fine, it's fine.
So I'm very thankful to the organizers for giving me this opportunity to speak upon very important aspect of ICBPS, that is the treatment. And as with other diseases, it will include 3 parts like conservative management, pharmacological treatment, and surgical options. So starting with the conservative one, there are many strategies. I'm going to cover one by one. The good part is that overall improvement could be up to 50%. And sometimes if you are combining the stress reduction techniques, then the improvement could reach up to 80%. And it should not be only the first part of the management, it should be the integral part of every level of management, starting with the patient education and counseling. So once you're disclosing the diagnosis to the patient, it's your prime duty to explain what happens in IC and what is the difference from normal bladder function. And next expectation would be whether there would be a permanent cure or not. So you have to educate them that, like other chronic diseases, diabetes, hypertension, there is no permanent cure, but yeah, with the early adequate treatment, they can have a good period of remission, and the disease can come back, and it is possible the treatment which was working will not work later on. So that's why you have to tell them all kinds of treatments available with all the risk and benefits of the treatments, so that they should not feel hopeless that there is no treatment if one is failing. Now coming to bladder retraining. So sometimes these patients start adopting their own coping mechanism, like drinking less or avoiding public toilets, thinking that it's a recurrent UTI. So you have to educate them that it's not going to help, because drinking less will cause more concentrated urine, which would be more irritant to the bladder, and also a prolonged postponement of the voiding can cause aggravation of pain. So these things should be avoided. And also active pelvic floor exercise, because already because of pain there could be pelvic floor spasm, and these exercises, the Kegels, can precipitate voiding dysfunction. Rather, they should do some kind of relaxation exercise or stretching exercises. And also they should adopt some kind of stress reduction techniques like meditation or yoga. And you can also introduce these patients to some dedicated patient support groups we already have in India, and we can share the numbers. Already Dr. Sanjay Pade described those groups. And coming to the dietary modification, though there are some controversial opinions for this, but we all agree that more than 90% of the patient will show their in their history that there is some association with food items. Though there is long list of foods which has been given from the Western world, but we as Asian differ in our dietary habits. So it would be a good idea to ask your patient to choose from their food list by their own, that what food items can cause problem, and then they have to avoid those food items for a while, say for a few weeks to few months. Once they are doing good, then they should start those food items one by one. So say they have taken one, and then they have to wait for 3 days. If there is no recurrence of symptoms, everything is all right, then they can continue having that. But if there is a problem, then they should blacklist that food, and they should avoid in future if it's causing problem. Most common food items which has been seen to cause aggravation of things are caffeine in any form, like not only tea, coffee, even the caffeinated drinks, Coke, Pepsi, or chocolates, dark chocolates, or chocolate ice creams, alcohol, and also the citrus fruits like lemon, orange, apple, pineapple, strong spices, red, green chili, and the black pepper, alcohol in any form, or artificial sweetness, and sometimes some milk products also, especially if old sour curd is there. The first and foremost expectation of the patient would be from you that there should be pain relief, immediate pain relief. So it starts with some mildest analgesic with the lowest dose, like paracetamol and brufen. If it's not working, then you can try some mild opioid like tramadol. If it's not working, you can escalate the dose. But if rare refractory pain is there, then probably it's a good idea to refer these patients to dedicated pain clinics. There are some kind of physical therapies also, like if you're able to figure out the trigger points at the time of examination, then either you can release or you can make patient understand how to do the massage or something. For that, it's sometimes causes a great improvement. Otherwise, you might have to might require electrical stimulation, TENS kind of therapies. At our part, we have a specialist for that, like physiatrists, so we can refer those patients to them. Also, there is a good idea to you can also do direct injection of trigger points with local anesthetics with or without glucocorticoids, but there's no any strong evidence for that. Acupuncture, actually this has a very promising results through many RCTs recently, and that's why it has been included in many guidelines and textbooks, and I'm sure at your part you must be having experts for that. Coming to the specific treatment, so we have already discussed the pathophysiogenesis of the disease. So drugs can work at different levels, like if epithelial damage is there, then gag-like therapies to heal that epithelium, like oral pentosan or intravesical heparin can work. If already damage is causing potassium leak and irritation of the nerves, then probably those medication which inhibit neurological activity, like amitriptyline or pregabalin or gabapentin can work. If there is activation of C fibers with mast cell release and histamine is there, then antihistaminic medications like hydroxyzine can work. So coming to the dose, always start with the lowest dose like amitriptyline with 10 milligram, and I always ask my patients to take it 2-3 hours before sleep to avoid hangover next day, because the side effects could be drowsiness, even palpitation, dry mouth could be there. If constipation is already, then probably it would be a good practice to give something for constipation beforehand. If patient is able to tolerate the medication but not full relief, then you can gradually escalate the dose to 25 mg OD to BD and even TDS. And the second drug is hydroxyzine. So it is a very useful drug in those patients who are having history of allergies like urticaria or bronchitis. Start with the lowest dose 25 mg. Otherwise, you can increase up to 75 mg per day, but you have to be very cautious in elderly population because of the side effect of drowsiness and confusion. The pentosan polysulfate, few words for that, because it's the only FDA approved oral medication, and we know that it's a biomedicine made from some bark of some German tree, so it should be always kept in cool dry place, and the dosing is very specific, 100 milligram 3 times a day, 1 hour before or 2 hours after meals. So it's very important, should be club with the food, because otherwise it will not have a good result. And the duration of therapy should be at least 3 months, because it's a slow working medication. If you are giving for the short duration of say 10 to 20 days, it will not give results. So that's the reason some of the studies have not shown the promising results, and even some guidelines have stated that it's not good, it's as good as placebo, which is not correct. We have seen very, very good response in many of the patients, though there are some side effects, but these are usually mild, nausea, diarrhea, and hair loss is usually reversible. Other medications could be azathioprine or cyclosporine. Cyclosporine is especially useful in those patients who are having active Hunner's disease. Coming to intravesical treatment, once the oral medication is not working or having a lot of side effects, then you can instill the medication directly into the target organ with a maximum response and without systemic absorption, so there would be least side effects. But it could have disadvantages like it's invasive, you are introducing a catheter, so it can cause aggravate urethral pain, and also there is a small risk of infection. These are the commercially available intravesical agents. At our place, we are only having heparin. The DMSO, dimethyl sulfoxide, is of industrial use only. AUA, the American Urological Guidelines, have only recommended these 3 agents, dimethyl sulfoxide, heparin, and lidocaine. We usually use combination, and you can see the publication of Dr. Taneja, and his cocktail includes hydrocortisone 200 milligram with heparin 25,000 units in 40 ml saline. Myself, I use this combination. The dose of heparin range from 25,000 to 40,000 depending on the severity of the patient symptoms, combined with bupivacaine 0.5%, sodium bicarbonate 7.5%, and dexamethasone 8 mg. We usually give it at an interval of 1 to 2 weeks for total 6 times. Rationale for this cocktail regime is that because the gag substitutes work slowly, so we combine with some kind of local anesthetic to give an immediate relief in pain, and alkalization increases the potentiality of the local anesthetic. Preliminary results of my data of around 676 patients, which I kept for 2 years, is very good. More than 50% response, but no response was only with 11% of the patient. There are some tips for doing these intravesical installation. If you are relying on some technician or nurse, then you have to tell that, ask patient to come having a good breakfast, because it's a good habit not to eat something during the installation time, because they will drink a lot, then it will fill the bladder fast, and they won't be able to hold the medication for a long period. Also introduce 10 to 15 minutes before some kind of xylocaine or some kind of local anesthetic jelly, so that they will not have pain during insertion, and use the smallest caliber catheter like 8 French pediatric feeding tube, and don't insert beyond bladder once the urine is cupping stop, because otherwise it can touch the various parts of the bladder wall and can aggravate pain later on. I'm not going to touch the cystoscopy part because it has already been beautifully covered by 2 previous speakers, so I'm skipping this part. Coming to the last last resort, that is the invasive therapies. It could be injecting botulinum toxin into the bladder, or neuromodulation or substitution, cystoplasty, or urinary diversion or cystectomy. So the few word about that, it should be the last resort, because once, because of active Hunner's disease, a lot of ulcers are there, and it has led to the contraction of the bladder. Then only you have to consider these kinds of things, and don't do partial cystectomy. It's a better idea to do the whole cystectomy or urinary diversion, because if there would be a part of a bladder which is left, it can have recurrence of the disease and can cause problem. Even you have to be very cautious with those patients who have developed central sensitization or are having associated chronic pelvic pain, because all their symptoms will not go with even with these kinds of major surgeries, which are having many other side effects. Coming to the BPS, if it is occurring in pregnancy, only two things are considered safe. One is oral amitriptyline, and second is intravesical heparin. DMSO can be given pre-pregnancy, but after pregnancy you have to avoid, because it is having a teratogenic effect. Now we know that there are so many treatment modalities available, but we still lack data. So I will ask you people even to keep your data, and we can collaborate to maintain some kind of randomized control trial so that we can help our own Asian patients. There are many guidelines which has come up time to time, from AUA in 2014 to CUA, that is Canadian Urological Association guideline in 2016, and they beautifully divided the patient based on the symptoms in various phenotypes, and in this way they were able to specify the treatments also. We also recently in 2017 have issued our own guidelines, GIBS guidelines, and recently it was updated also, and it is more relevant for the Asian patients. So my take-home message is that yes, if a patient is coming to the early stage, as we have described in our guidelines, you can follow this stepwise approach. Start with oral non-specific medication, not working, then specific oral medications. Next would be diagnostic cystoscopy with or without hydrodistension, and you can ablate the Hunner's ulcer at the same sitting. But if it is not working, intravesical treatment, and last resort would be invasive therapy. But if patient is coming to advanced stage, it's not that you have to start with the first treatment. You can start the advanced treatment, or you can combine 2-3 treatments together. You have to individualize the treatment, and it would be a better idea to phenotypically decide the patient's treatment, and in order to achieve the maximum response. And if the multimodal therapy is not working in a patient, then you should rethink about the diagnosis, and you should evaluate that patient further. And the last thing is that always avoid long-term antibiotics, oral steroids, or long duration high pressure hydrodistension or intravesical BCG in these patients. So with this, I think I have justified the treatment part of this disease. Thank you so much. Hello.
Thank you, Dr. Amita. You did a wonderful job. And I think we are ready for the next session. But I do not have too many questions, so I decided to talk about few things myself. The first thing that I want to talk is that, of course, we are having such a wonderful webinar, and that is because the interest is rising, which is very important. Because for the diagnosis, if your level of suspicion is high, if your suspicious index is high, the diagnosis becomes clear, because you have to make a diagnosis out of almost nothing. It is making a diagnosis in thin air. So I will just point out few things which have been missed in the whole of the scenario, which I wanted to talk about. One is, of course, you need to phenotype your patients. There will be patients, as my previous speaker talked about, in etiopathogenesis. So there are various etiopathogenic pathways, and it is a heterogeneous entity. So you need to phenotype which patient belongs to which category. For example, some patients will have Hunner's lesions, others will not have Hunner's lesions. Some patients may have no bladder pathology at all. So that means there may be some neuropathic pains. There, up to 85% of these patients may have dysfunctional voiding. So dysfunctional voiding can cause bladder pain. And the point is that if you do a cystoscopy, you may find absolutely fine. And all you need to do is to find out if they have an overactive pelvic floor, which can be done by a good pelvic examination. So you need to phenotype and then progress further. The other is, of course, if you find a person with a tight pelvic floor, you subject them to good physiotherapy. The problem with physiotherapy is that if you send it for physiotherapy for pelvis, they give them pelvic floor strengthening exercises, which is absolutely opposite to what is required. So they will increase the symptoms rather than decreasing the symptoms. So we need to tell our physiotherapists to prescribe pelvic floor relaxation, because most of the times patients come back with Kegel exercises, which increase the symptoms. So that is very important. So have a dedicated physiotherapist, teach your physiotherapist. Then, of course, we have for the basic practitioners, I wrote a book on interstitial cystitis in 2014. It is readily available. If somebody wants and cannot have it, can just send me a message. I'll see, or BP can organize that. The other is, last year we were one of the first ones in the world to have local diet book. Like we have got an Indian diet book for our part of the world for interstitial cystitis, bladder pain syndrome. So because our diet is different from Europeans, our problem was that our patients would come and ask about diet, and when they go back to web, they will find things which they are not eating anyway. So we had to compile a book on that, and that is also available. Regarding oral pentosan polysulfate, as Dr. Amita has rightly mentioned, that it is controversial. It is not controversial. I have just reviewed all the studies while I was in the lockdown, and I realized that the studies in which cystoscopic findings were supposed to be good were included in the inclusion criteria of the study. Pentosan polysulfate worked in all of them. It did not work in the studies where cystoscopy was not supposed to be a part of inclusion criteria, which means that they collected a lot of other heterogeneous group of patients, and then they gave them pentosan and found that it is not working. So you need to select out your patients. You just don't keep giving pentosan polysulfate to everybody. So your diagnosis has to be important. If your diagnosis is correct, it is likely, I'm not saying it will, it is likely to work. So we cannot write off a molecule like pentosan polysulfate. The problem is that there is one study published by Curtis Nee in 2015, because of which the whole thing changed. But the same group had published in 2005 and had given kudos to pentosan polysulfate with a result of more than 65-67%. So in 10 years, the molecule giving result for 67% has become a molecule giving result which is not acceptable. So what has happened in 10 years? Is a temporal profile of a molecule globally changing the pharmacotherapy? I don't know. So what I found was, the reason was that the study they published in 2005, they had strict criteria of cystoscopy included in their inclusion criteria, which was not there in the 2015 study. So that makes a big difference. Regarding one more thing, I would like to say that we need to have a kind of clinical scoring system. We have the ICSI, HoLEP, SAND score, and but we can have our own systems. I have one of them. If you want, you can accept it. So I see that there are not many questions, and I would like to then go ahead and ask about the next speaker. So the next, yes, Dr. Pawan.
Yes, sir. There was few concern regarding the duration of hydrodistension and the proper technique. I think our residents also need to tell it properly. So I think Dr. Apul Goel, so if he's there, yeah, I saw him.
Yes, yes.
So,
yes, he's there. He's very much there, and he's going to be part of the panel.
Yeah.
And he's smiling away.
Yes. So can you highlight, sir, about what's the exact duration, how long it should be done, and what's the proper technique? So your mic is mute, so please.
So as Dr. Shivam was saying, actually hydrodistension and cystoscopy, all these are, sort of controversial. And as was discussed, there's no atlas actually of Hunner's lesion, because there's lots of emphasis of whether we need to differentiate between Hunner's disease and non-Hunner's bladder pain syndrome category. So actually there's no atlas. So what they say is that it has to be in a non-distended bladder. The second point that you were asking was how long you need to distend the bladder. So I think, as Dr. Shibam, I'll agree with him that I think 2 to 3 minutes, what he said, seems to be appropriate. I'm not sure what Dr. Taneja will like to add on this.
You actually summarized everything. See, there is a difference between hydrodistension and hydrodilatation. Initially, the confusion has arisen because initially it was 8 minutes. So 8 minutes, if you distend beyond 80 centimeters, you're going to actually kill the detrusor because you're going to go beyond the diastolic pressure. You're going to cause ischemia of the detrusor, and the detrusor can get paralyzed temporarily or in certain cases quite substantially, and the recovery may not be as good. So it was decided to do hydrodistension rather than hydrodilatation. So if you need to distend, the aim of distension is to disrupt the nerve endings in the submucosa. That you need only for 2 minutes. 2 minutes is good enough to do that. The idea is to disrupt the nerve endings and kill the pain circuit, because it is a neuropathic inflammation, which means pain causes inflammation. In most of the cases, it is inflammation that causes pain. You get hit, you get inflammation, it causes pain. No, in this, it is the pain which causes inflammation. So if you do a hydrodistension, you kill the nerve endings which are causing pain, and the pain subsides and the inflammatory cycle is cut short. So that is the idea of hydrodistension, apart from increasing. Yes, Dr. Apol.
The latest edition of Campbell, they also mention about 2 minutes only.
That's right. No, initially it was 8 minutes in most of the books, including the NIDDK trials.
So now it is for 1 to 2 minutes.
Yeah, that's good enough. That's good enough. So if there is nothing else, we can move on to the presentation for the case discussion. So I invite the panelists. My co-panelists are Professor Shivam Priyadarshi, Professor Rapul Goel, Dr. Amita Jain, and I invite our master, Dr. Sujit Podial, the quiz master, who is going to start and take over the stage. Please, Professor Sujit, over to you.
Dr. Sujit, your mic is mute. Yeah, thank you.
So good evening, everyone.
Hello, good evening. We are there with you.
So I am thankful to Naus and GIBS for letting me be a part of the program and also be a moderator of this session. So we have a team of esteemed panelists. So they will be enlightening us and demystify this so-called mysterious syndrome. So without any much to do, I would like to start with the case. So coming to the first case, she's 28 years female with lower urinary tract symptoms with frequency deteriorating for 6 weeks, currently voiding every 30 to 60 minutes. She has nocturia 3 to 4 times. She also gives history of severe suprapubic discomfort compelling her to void regularly. She gives history of recurrent lower urinary tract symptoms for 15 months and for which she has received multiple antibiotics, anticholinergics without any relief. She claims that her urine culture was always negative and she is currently taking NSAIDs for pain, but without any complete sense of relief. So she says her voiding is satisfactory, but she has difficulty voiding during dysuria. She gives history of dyspareunia, no hematuria, no urinary incontinence, gives history of intermittent headache, relieved by paracetamol without any pain at other sites of the body. She gives history of constipation, but now relieved with change in diet, no history of vaginal discharge. She is regularly menstruating, but gives history of suprapubic pain, which increases few days prior to menses. There is no significant past history, medical illness, or allergy. So I'd like to start with Dr. Rajesh. So what inference can we get from this history and what further history we need to ask?
Yeah, I think since Dr. Amita is there, I would pass on this question to Dr. Amita, please.
Okay, sure.
So I can see that the history patient is very specifically saying that it's a suprapubic discomfort, which is compelling her to void. So that's a differentiating feature because of the urgency. We have to ask patient the urgency or the thing which she is getting is not the fear of leak. She is going for the void because she is having discomfort, which is also relevant in the evident in the history. So that is the differentiating feature from overactive bladder. Um, the most common diagnosis which is made for these of the symptoms is recurrent UTI. So we have seen that urine cultures are negative, so it's ruling out the UTI. And the thing on the next slide, you have shown the menstrual history there, where she is saying that there is suprapubic pain which increases just prior to menses. So that could be a differential diagnosis. This patient should be further evaluated for endometriosis, which is a differential diagnosis. And for that you need a good clinical examination, pelvic examination, and ultrasound of pelvis to rule out endometriosis. So these are the things I would like to highlight. And the examination part will also give you idea any kind of, trigger points, pelvic floor spasm or something which is causing aggravation of thing, because these patients are prone to develop voiding dysfunction later on. So that's my view.
So thank you, Dr.
So
Amita.
I will add on something. Yeah.
Okay, thank you.
So,
Okay, sure, sir.
so
Please.
the simple question that I would have asked is, when you wake up from sleep, is it
Yes.
the pain that is causing you to wake up, or is it the bladder sensation which is causing you to wake up? Because if it is pain, then we know that yes, there is a problem. Another thing is, of course, when Dr. Amita, that is why I put it to Dr. Amita, because a change with a menstrual cycle means that there could be something else sitting there, which could be an endometriosis. Anything else, Dr. Goel, you want to add?
No, I think Dr. Amita has, said everything. And you need to keep endometriosis in mind, because as urologists, we often miss this thing. So, because as a gynecologist, so she picked up, endometriosis, which has to be always kept in mind. Otherwise, this lady, except for the fact that she looks a bit young, actually. So, although even this condition is described in children, but otherwise everything falls into into this bladder pain syndrome category.
Yes, sir. So this the history gives clue towards bladder pain syndrome, but we have to rule out endometriosis. So to complete this history, I would like to add that she gives history of generalized weakness, loss of appetite and weight. She is insomniac, no interest in work. She is housewife, married for 5 years with one child. Her husband works in Dubai. She has received high school education. There is no significant family history, and she is from low middle class family. So does this history adds up to anything? So, Dr. Rajesh.
Yeah.
We need to take
when you say insomnia, I need to understand, is it truly a nocturia or a nocturia because of insomnia? So the question that I would ask is, okay, when you wake up from sleep, you go to pass urine, you come back, do you go off to sleep immediately? If you're not sleeping and you're tossing in bed, you've got nothing else to do, you just walk up to the washroom, and that is counted as nocturia. So one has to be very careful when you talk of insomnia with nocturia together.
So, yes, sir.
I want to add one thing.
And loss of weight has to be accounted for. Never in ICBPS you will have a loss of weight unless there is a functional overlay and there is a functional problem of anorexia, which we need to assess.
So we have a lot of differential diagnosis.
One thing I want to add, that we can see a lot of stress factor. We can see a lot of stress factor, like she's having insomnia. That could be because of the disease, but she has to bear the child. Her husband is away, and So there could be, we have seen that stress induces the flares. So that
Yes.
could be the reason for her recurrent symptoms. So that could be the one thing, because probably she is not having the diagnosis till now. She was diagnosed as recurrent UTI. So she must be having that stress also, that she is not having the diagnosis. So sometimes these things also aggravate the scenario.
So, yes, sir. So whenever we are dealing with chronic pain, so we have to dig into the psychosocial aspect of the person as well. So these are the DDs. So we have ruled out most of the differential diagnosis. So any comment on this differential diagnosis, Dr. Apul?
So I think you have enumerated all possible differential diagnosis here, and as you have highlighted, because although the condition is bladder pain syndrome, but if you see 75% of these patients will have associated symptoms.
Yes.
Only bladder centric disease is only 20 to 25%. So as you have mentioned that this lady has other symptoms also, like anxiety and headaches and all those things. So I think she is, falling towards the last differential that you have mentioned, which is the bladder pain syndrome.
So yes, sure. Bladder pain syndrome should be suspected at first, but should be diagnosed at last after ruling out all the differential diagnosis.
It's a diagnosis of exclusion.
Yes.
Yes, Dr. Shivam, please.
Yes.
Yes.
Thank you. Amongst the history, one of the components of the history was that she has loss of weight and loss of appetite also. So being in this part of the world, we should always rule out a case of genitourinary tuberculosis also.
Yes, yes.
Yes, though these symptoms could be due to psychosomatic also, maybe it's because she has been suffering for so long. So that could be something related with psychological disorder also, but we should rule out genitourinary tuberculosis. The secondly, about endometriosis, typically endometriosis will have pain during menstruation and not just before menstruation, which is quite typical in interstitial cystitis. And patients with cyclic hematuria, which is present in around 20% cases, is probably diagnostic of urinary endometriosis. While diagnosing a case of endometriosis urinary, we have to think that ultrasound and anything else, physical examination may not pick up endometriosis, urinary endometriosis. So many of the researchers and clinicians have suggested that laparoscopy should be done together with cystoscopy in these patients if you are suspecting endometriosis, because endometrial lesion always starts from the serosal surface, from the peritoneal. So you will have peritoneal lesions and you may not find anything in the bladder itself. Bladder endometriosis usually is presented only when there is a deep infiltrating endometriosis, which is present in some of these cases. And if they present into the lumen of the bladder, then only you will find bladder lesion, which is obvious on ultrasound. So laparoscopic, diagnostic laparoscopy would be required if you want to rule out endometriosis in this.
Yes, sir. So that's the point.
Yes, I will just add on one point that as Professor Shivam has rightly pointed out, in the late 1900s and 2000s in Europe, there was a trend to do all these hysteroscopy, cystoscopy, laparoscopy for any pelvic pain. But then that was overkill. But what he has just mentioned is absolutely right. If there is any clinical hint that there could be an endometriosis, one should not shy away from doing laparoscopy at the time of cystoscopy.
If I might add something here. Because in last one of the conferences, I just presented on endometriosis of urinary bladder only, and its relation with interstitial cystitis. I will tell you a few facts. These conditions, both IC, BPS, and endometriosis, are considered as evil twins of chronic pelvic pain syndrome. They are described as evil twins, right? And 50 to 80% cases of endometriosis have interstitial cystitis. Patients have 4 times higher chance of having interstitial cystitis if they have endometriosis. 80% of patients of chronic pelvic pain syndrome may have interstitial cystitis. And many of these patients, we do hysterectomy. And after hysterectomy, almost 1/3 of these patients still continue to have pain. And 80% of these patients are thought to be actually interstitial cystitis. So these are a few facts, and almost 2/3 of these patients may have interstitial cystitis and endometriosis coexisting. So they may coexist together. And researchers have also shown that endometriosis can lead to interstitial cystitis. So these are a few facts about these two conditions.
What would be the message, sir? I think the message to gynecologists should be that at the time of treating endometriosis, especially if they are doing a kind of hysterectomy or something, always they should do a cystoscopy to rule out the presence of interstitial cystitis or even the bladder endometriosis. So that should be taken into account. I think this is the message which should be.
Before proceeding with such a radical kind of surgery, we should always think in mind of interstitial cystitis also. Right.
Okay, thank you very much, Dr.
Confined to bladder, yeah.
Okay, so BPS is not a single entity, as we all know. We have been discussing this, and so whenever we deal with bladder pain syndrome, we have to dig into every aspect of the person. We have to rule out systemic diseases, regional pain syndromes, even psychiatric illness. So coming to examination. So her general physical examination was unremarkable. BMI was 21. Abdominal examination revealed mild suprapubic tenderness. Vaginal examination revealed mild anterovaginal tenderness. Her neurological examination was unremarkable and pain score was 7. So Dr. Amita, anything to add on this examination? Excuse me, Dr. Amita.
Okay. So these are the examination findings. So yes, we do my bimanual examination. Can you switch over the slide again?
Okay.
We do the bimanual examination. So that would be the part which is missing here, that we see the pelvic organs by keeping one hand inside the vagina and other on the abdomen. So to know about the endometriosis and any kind of endometriotic cyst in the ovaries and any kind of tenderness, that bimanual examination is important.
Okay.
And
per
rectal examination also we do in these kinds of patients, because even the endometriosis can affect the rectal part. And of course, in history, you have to rule out the symptoms also.
Okay, thank you very much, Dr. Amita. So now coming to this frequency volume chart, how important is frequency volume chart? What information can we get from this frequency volume chart? So Dr. Rajesh.
Yeah, this is very important, because a lot of people would come and they will tell you that they have a lot of frequency, but then if you ask them, they will drink 2 liters of water when they wake up. So that is something which needs to be discouraged. So frequency volume chart has to be maintained, because that is going to make life much better. And it is, see, in this case, the maximum volume is 170. And although the patient has not had too much of water, the output is within range 2 liters almost. And if it is 170 ml per void, then perhaps she has a restrictive bladder. Now that means the bladder is not able to hold. If bladder is not able to hold, either it is already inflamed or it is fibrosed. So since it is a short history, I don't expect it to be a fibrosed bladder. But here is the thing where one should consider seriously cystoscopy, because the bladder volume is low. Because this is one of the clinical indicators that if patient is waking up at night or whenever she has pain suprapubically on full bladder, which gets relieved partly on passing urine, and the capacity is 170, it is likely to be a transmural inflammation of the bladder. This is the inference from this kind of an investigation, which is very simple and cheap. So I would be keen to call it a small capacity bladder, and would like to think about that this patient may require, after we've investigated, cystoscopy for a therapeutic purpose. Of course, we will be doing a diagnostic for all, but then this also may require for a therapeutic purpose. So small capacity bladder, if the pain is not there and I have the same thing, then I will think of, you have to look at urine cytology. There may be a small papilloma at the trigone. There may be carcinoma in situ, which can give rise to this kind of frequency, urgency, small capacity volume in the absence of pain. But if the pain is associated, which the patient must certify every time you ask that question, that do you have pain which gets relieved on passing urine or tends to get relieved on passing urine? Then of course we consider inflammation. And she's
Thank
too young. Yeah.
Dr. Rajesh. So we all know frequency volume chart has lots of information to give. And
Dr. Shivam is there. He's pointing his finger.
Yes. Can I speak?
Okay.
Can I speak? Yes. Thank you. This about the frequency volume chart. I would just like to remark that small volume, frequent, and if the volumes are regularly small, then it goes much in favor of interstitial cystitis. We won't say that this is a small capacity bladder because usually these patients will have functionally small capacity, not actually anatomically small capacity, may not be there. One more thing that we can decipher from this is that the intake is not high intake, right? Sometimes some patients may take a lot of fluids and which may cause frequency. So his intake is normal and even then he has frequency. There is no incontinence. So we can rule out overactive bladder. Overactive bladder, again, the frequency will not have, the low volume would not be regular. Sometimes they may have normal capacity urine output and sometimes they will have low. So these are a few differentiating features by which we can say, suggest that it could be IC or otherwise.
So I would like to move on to other investigations. Our urine routine revealed 2 to 4 pus cells. Urine AFP was sent, which was negative. Urine culture was negative. Ultrasound abdomen was done, which showed normal scan with probe tenderness at suprapubic region with pre-void urine of 160 ml and post-void urine of 10 ml. And uroflowmetry revealed Qmax of 16 ml per second with volume of 103 ml. So any comment on these investigations, Dr. Apul?
I think this is okay. This is moving in favor of interstitial cystitis, the bladder pain syndrome. So although urine AFB is not, it is a specific but not very sensitive, but still this is the best we have. And culture is negative, so we have ruled out urinary tract infection. Urine RM is, pus cells are almost normal. And ultrasound is also, it's just reconfirming what we saw on the this voiding diary. So I think there's nothing much information that has come up. It's already, this information we were anticipating actually.
So what further investigations would you like to go first?
See, actually, there's no urinary marker for interstitial cystitis. Basically, it's a diagnosis of exclusion. So we have practically excluded all the things. Ultrasound has excluded. So I don't think we need to investigate her further. And I think we can start therapy.
Okay. So, Dr. Rajesh, any comments, sir?
No, I think this is absolutely fine. And there was a query that I received, the role of urodynamics, because we talked about small capacity bladder. But the point is, in the presence of pain, in another person where there is no other lesion and there is no other symptom, then one may do a urodynamic evaluation complete. But if somebody has pain, then in the presence of pain, the urodynamics becomes more painful and the results are erroneous and cannot be duplicated. So I would not be keen to do urodynamics for a small capacity bladder with pain.
Okay, thank you, sir. So what about clinical symptom scales? There are so many symptom scales. So in clinical practice, which one is better or which one is pertinent? So I'd like to ask this question to Dr. Amita. So Dr. Amita?
Can you hear me?
Yes.
Yes, yes. Now we can.
So we usually using Olani scent in indices because it's having all kind of things combined. And actually we have raised in our last GIBS conference that we can include a few things more in that clinical scale. And I think Dr. Taneja got a publication also regarding that aspect. So we are using, but yeah, I am not having details of other scales, so I have no idea. I think Dr. Taneja will give a better answer.
Okay.
Yeah, so I have the bladder pain syndrome scale, which was published in International Urology, which is based in Japan. Now, this scoring system, I decided to incorporate the dyspareunia or the sexual dysfunction and pain during sexual function, and the functional or the psychological impact. And then what I did was I multiplied the pain factor to 4 times and nocturia again. So that is a detailed discussion. I don't want to come into it, but then I have that system that is working. If anybody is interested, I can forward it to them. Otherwise, it is available in the International Journal of Urology in the year 2019. I can send a reprint if you can send me a mail. But some kind of scoring must be done. The scoring is important because, very important, because if you have a score and the patient comes back and says, look, doctor, you have treated me, but I'm not better. You ask them to fill this, the scoring system before they see you. And then you compare that scoring system from the first day that they had come. And then even if the patient doesn't realize, patient has improved. So that gives a positive biofeedback to the patient. So the scoring system works therapeutically. It not only convinces the patient that patient has improved, but also helps the patient. Patient will go back and understand, yes, I have improved. Otherwise, the patient will keep telling you, because pain sometimes is very unquantifiable thing. So the patient will keep saying, मेरे को पहले भी दर्द था, मुझे अभी भी दर्द है. But then the quantification of symptoms has to be there, which helps the patient to understand and go back with a more positive attitude. That's where it works, positive biofeedback. So you can follow any scoring system, whichever you want to follow, you should follow. This is the one that I followed, which has been published. If you want, I can share.
Yes, thank you, sir. So clinical symptom scale, they are essential component of the investigation, and it's necessary for objectification of the progression of the disease. Thank you. So this is the O'Leary scent score, not going into detail. So further investigations were also done. Urine PCR was also sent, urine cytology was also sent, cystoscopy was also done. So as we have already discussed, these investigations are not necessary. So any comment?
Yes,
Dr.
I would like to. Yeah, okay, let Dr. Shibam start off. Yes.
I think if we have we are thinking that she has loss of weight, loss of appetite, and systemic signs and symptoms of chronic disease, then we should do a tuberculosis culture also, AFB culture and PCR also. And about urine cytology, I don't think it is required. Urine cytology would be required only if we have a microscopic hematuria, or because she is female, I don't think she is a smoker. So if she is a chronic smoker or microscopic hematuria, then only we will think of doing a urine cytology. Office cystoscopy, I think because it's a prolonged, she's suffering for a prolonged period. So personally, I think that I would go for a cystoscopy to rule out a non-Hunners from a Hunners kind of ICBPS.
Okay,
so other confusable lesions also, right?
Yes, thank you, sir.
So, Professor Sujit, now I have two problems here. One, I have not been able to explain the cause of weight loss. 5 kg weight loss is significant in a young woman. Unless I am convinced that this is depression and anorexia due to depression, which we need to evaluate.
Yes.
The other is that she has suprapubic pain. Suprapubic pain comes from pelvic organs. What is the status of her large intestine? Sometimes they will have something like an ulcerative colitis, which has not been diagnosed, or maybe a terminal ileum or an ascending colonic Crohn's disease, which can cause malabsorption and reduction in weight. We need to be careful because there can be a crosstalk. So I would be keen to evaluate this person from a different perspective altogether while I'm working on his bladder. So I would need to get a gastroenterologist at this point of time. Let the gastroenterologist define the cause of weight loss. This is very important. Second, I don't recommend an office cystoscopy because office cystoscopy, one, has done under local anesthesia. Two, it is done with flexible cystoscope in most of the places. So when you have an office cystoscopy and the patient has pain when you're causing infusion, irrigation, you cannot see many places. Sometimes you may miss a lesion because patient is moving and it is a moving target and you're trying to find out and the patient is struggling. So I think if we cannot relieve the pain of the patient, we should not give pain to the patient. So although there are centers which will keep continuing to do office cystoscopy under local anesthesia, I'm a strong recommender of cystoscopy under general anesthesia so that you take an opportunity to treat if you find something. And because why is the patient having pain? Because the bladder is getting filled and the pain and the bladder is not able to hold that volume. So you are fighting with the patient. The patient wants the bladder to be empty. You are fighting with the patient to fill the bladder. So that is where the thing is. So when there is you're working on two opposite ends, and that is a struggle, and you may not be able to do justice to cystoscopy. Dr. Shivam wanted to make a comment.
Okay.
Yes, I wanted to say that cystoscopy is, I would do cystoscopy, not office cystoscopy. I usually don't do office cystoscopy in these patients.
Okay, thank you, sir.
Yeah.
So as we all know,
I
it's
have one question to Dr. Taneja. So suppose there is no bowel symptoms, her bowel habits are completely regular, even then you can suspect and you will have a GI reference, sir, for this particular patient?
I will tell you, Dr. Amita, who takes responsibility of weight loss. If a patient walks into my chamber and says weight loss, no urinary symptom or some unrelated stone or anything, the first investigation is we send them to gastroenterologist. It could be a lesion in the stomach, it could be lesion anywhere. They have to find out whether they do a urine for occult blood or whatever. Weight loss is a gastroenterology problem primarily, and it's our responsibility. If I cannot explain, suppose Dr. Shivam does a IVP or CT scan and finds a tuberculosis, I'm very happy. I'm not going to send. But if I don't find that, if I don't find BPH should not cause weight loss, that's the only point I'm trying to make. Then you may need a colleague to help you because you cannot let the patient suffer. We are treating something, but the patient keeps on losing weight and we miss a lesion that could have been treated.
I totally agree with Dr. Rajesh Taneja. So we need to exclude other diseases, as BPH is a diagnosis of exclusion. So as we have already talked about, so cystoscopy, if done, it should be done under anesthesia, not office cystoscopy. So these are useful for ruling out other bladder lesions. To identify honor lesions, we can do narrow band imaging, assess bladder capacity and reproduce pain, but not in anesthesia. So we can also, there's anesthetic challenge test. So I think Dr. Rajesh Taneja has a comment to make in this anesthetic challenge with alkalized lidocaine.
That's right. So yes, I used to do that and I'm still doing it when I'm stuck with a patient. So if I'm not sure whether this patient has a pelvic pain which is related to bladder, whether it is coming from intestine or whether it is coming from the uterus or endometriosis, a simple thing is to put in an anesthetic challenge, and that works. This was published in 2007 or maybe 2010 in the European Journal. But this I find very useful.
So thank you, sir. So about diagnostic cystodistension, we have been talking about cystodistension a lot. So I think this is not recommended because it has low specificity for diagnosis. I think we all agree with this, no, sir?
Yes. it is not diagnostic. Yeah.
Yes. So biopsy, when to take biopsy, sir?
Yes, you see, if you do a cystoscopy and you find a lesion, you must biopsy it. That
Okay,
is the
sir.
primary thing all urologists are taught. If you
So
find something, yes.
for glomerulations, do we need to take biopsy or not?
Yeah. See, you must understand glomerulation is a bleeding spot. So the bleeding spot, and if there are multiple bleeding spots, and the mucosa was normal before you walked in. So when you're evaluating the bladder is being evaluated at partly distended state, and the mucosa is not stretched. So if there is no lesion at say 100 or 150 ml of bladder, then you don't need a biopsy. So what happens when you distend it, and you distend it to say 500 ml, then there are glomerulations and there are cracking and it starts bleeding, then there is no point doing a biopsy, because
Okay,
these are the lesions created by you and your hydrodistension.
okay,
So
thank you,
when
sir.
I say if you see something at partly filled bladder, you take a biopsy.
Okay, thank you, sir. Thank you for the information. So there is no histology pathognomic for BPS. We all agree with this, and biopsy is done to rule out other bladder lesions. So is there any risk of bladder cancer or upper tract urothelial cancer associated with BPS, sir? Any comment to make?
Yes, I have seen many patients who were treated for pure urgency or pure bladder pain for 2-3 years, and have done cystoscopy because the cytology was suspicious, and I have got urothelial cancer in 3 patients who were being referred to me for intractable frequency of urination. One of them had pain, 2 did not have pain, and I have seen 3 cancers of bladder. So I'm very good. I strongly agree when you did a urine cytology for your patients, because we don't know what they, and one of them was squamous cell carcinoma. So despite cytology being negative, we could pick it up, but then there was urothelial malignancy in 2 cases, and third was squamous cell carcinoma. So I think it is very important. That is why cystoscopy becomes imperative, because if you don't do cystoscopy, you may miss a lesion which was treatable. Yes, Professor Shivam.
First of all, the statement that risk of bladder cancer with BPS, does it mean that BPS may cause bladder cancer? If it means,
No,
then it's not, right?
no.
We
Yes.
may confuse it with carcinoma in situ sometimes. That has to be ruled out. But I don't think that every patient with these symptoms require a urine cytology. Patients with microscopic hematuria, patients who are chronic smokers, or a family history or something like that, then only we need to do a urine cytology. Not every patient who has symptoms related with lower unit tract symptoms, which seems to be BPS, needs a urine cytology.
So thank you, sir. So we all agree that BPS is not a pre-malignant condition, but it's a case. It may be a case of misdiagnosis. So recent study, Taiwanese study, has shown that male BPS patients have 12 times hazard ratio for diagnosis of bladder cancer. Similarly, female has 3.5 times misdiagnosis. So it may be cases of misdiagnosis only. So BPS as it's not a pre-malignant condition, but so we have to be aware whether we are over-diagnosing or under-diagnosing the case. So any comment to make?
Yeah, I think in my last slide, I pointed this out that if you have initiated the treatment of bladder pain syndrome, considering this the diagnosis, and the treatment is not responding, then you should rethink about the diagnosis, and then only further evaluation, even cytology and everything should be done if you are suspecting that that your patient is not responding. That is very important. Even Dr. Shivam is right in that thing that yes, initially you can skip, but if the treatment is not getting response, then probably you should think to avoid these kinds of situations.
Okay, thank you, Dr. Amita, for the information. So role of urodynamics, we all have been talking about the role of urodynamics. So whenever we come across dysfunctional voiding overactive bladder, urinary incontinence, or neurological conditions in history and physical examination, we have to consider urodynamics. So whenever we do urodynamics, we also need to consider video urodynamics in complex cases. So any comments to make, sir?
No, I think this is fine. You need
Okay,
to choose out your patients. Professor Shivam, any comments?
I just wanted to say that it is not a routine investigation in these patients. Urodynamics would be required in a very subset group of patients where we are confused whether this could be a case of neurogenic bladder or if the patient has some obstructive urinary symptom. Particularly if a male patient, we think that he may be suffering from BPS, we might do with obstructive symptoms, then we might do a urodynamics to rule out any obstructive pathology also. So not every patient would require a urodynamic study.
So if we do urodynamics in these patients, these are the findings. So here you can see normal compliance, no overactivity. So there will be only hypersensitivity. So in this case, the first sensation was at 63 ml, first desire to void at 95 ml, strong desire to void at 118 ml, and maximum capacity 138 ml. So similarly, voiding phase was normal. So I think it didn't add up to our diagnosis.
Right.
Just introduction of our symptoms only.
Yes.
So, Dr. Sujit, I must
Yes.
tell you something. If you see the maximal cystometry capacity is 138 ml, which means it is less than what the patient can hold otherwise.
Yes.
So patient has given a frequency volume chart saying 170 ml, and here the urodynamic says 138 ml. So this proves my point that in the awake state, if the patient has pain, you are trying to fill the bladder and the patient is resisting filling the bladder, and that fight will continue. That's one. Second is, if you look at the production of urine per minute, so the production of urine is per 1 ml per kg per hour, which means almost if there's 60 kg person, it is 1 ml per minute. So when you're doing a urodynamics, so what you're adding is actually 10 ml per second, per minute. 10 ml per minute is what you're irrigating. So which is a very high rate of filling of the bladder. So that is another reason why in awake state, patient with bladder pain syndrome will document a smaller bladder cystis capacity.
Okay, sir. So this is our pressure flow study. So what about other investigations? CT, MCVG, urinary markers, potassium chloride test. Any comments to make, sir?
So let me, come back again. So these are not done actually. These are only done as for urodynamics. Also, if you are stuck, the patient is not improving, you need to rethink about the diagnosis. So, and these urinary markers, they are still not standardized. They are still experimental, and they are only done only when, you are doing a clinical trial or something. And potassium chloride test, because it aggravates the symptoms. So, so people avoid it. It was described long back, but because you may aggravate the symptoms, you may induce the pain. So this test is also not done now.
Okay, thank you, Dr. Apul. So these, for initial diagnosis of BPS, these investigations are not necessary. Okay, thank you. So as per AUA guidelines, to conclude our history physical examination and diagnosis. So for simple case of BPS without any incontinence, GI symptoms, signs, hematuria, hysteral pyuria, and gynecological signs and symptoms, so basic assessment is enough, which includes history, frequency volume chart, examination, post-void residual urine, urinalysis, and symptom questionnaire along with pain evaluation. Cytology is needed if there is high risk for bladder cancer. And for advanced diagnosis only, we need to consider urine cytology, imaging, cystoscopy, urodynamics, and these all depend upon the discretion of treating urologist. So any comment to make, sir, in this AUA guidelines?
No, I think this is perfect.
Okay, thank you, sir. So what about phenotyping of BPS? So we have been talking about we need to phenotype BPS. So BPS has been phenotyped by different guidelines, by different association in different ways. So some phenotyped as honor type, non-honor type, some as phenotyped clinically as input system, ASIC, has used cystoscopy, biopsy, some has classified it as pelvic pain only and pelvic pain and beyond, some, some as bladder centric with low bladder capacity and non-bladder centric with large bladder capacity. So how to phenotype BPS? Any comments?
Yes, if I can just come in. Yes.
Yeah, please.
So as I said, I think if we start any treatment of BPS, phenotyping is most important because this group of patient is a heterogeneous group of patient. They have varied kind of symptoms. And so phenotyping the patient would help us to treat the patient in a proper manner. So we know a U-point system has been described by Karen, which was way back in 2009. And then they added also one point, that is S was for sexual dysfunction also added. So according to this, we all know that we can just phenotype or the exact clinical domain in which this patient falls and then treat the patient accordingly. And I think it's very important nowadays, a lot of work is being done to understand whether actually it is different entity or it's a part of ICBPS only. So people are saying that this Hunner's lesion IC could be a totally different entity than BPS. So we have to see whether it is actually a Hunner's lesion IC or it's just a systemic disease with BPS, or even there is third entity which is called as pelvic hypersensitivity. So in physical examination, that just I was going to mention that we just missed out about pelvic floor examination. So we need to see the tenderness of the myofascial bands and tenderness, all those areas, to know whether if there is something wrong with the pelvic floor muscles also. So these three are the most important entities which need to be differentiated from each other before we start the treatment.
Yes, Dr. Shivam, Dr. Amita did mention about the trigger points and pelvic floor examination. So she had mentioned. And
in this particular case, I'm not asking about Amita's presentation. This was regarding this case.
This case only, she talked about when she was made to make the comment. Anyway, so the only thing is that there have been phenotyping based upon what presents, like people have phenotyping, trying to phenotype. When you're talking about Hunner's lesion, it is the manifestation. So the phenotyping should be done based on etiology. If you want to succeed in segregating the treatment, you should be able to do phenotyping based on etiology, and more work needs to be done on this regard at that level. Yes, Sujit, please continue.
Okay, thank you, sir. So AU has given strong recommendation on phenotyping of these patients for treatment, as these patients are really heterogeneous. So, and these have implications in diagnosis, prognosis, and treatment. So now coming to treatment, patient was counseled regarding her disease, the disease process, and she was advised for behavioral modification like restrictions of diet and to restrict diet that provoke symptoms, to engage in meditation, and also advised about concept about bladder training with urge suppression. So we started analgesics according to WHO ladder pattern, and amitriptyline was started 10 milligram daily, and it was titrated weekly to 50 milligram. So she was treated with multidisciplinary team of gynecologists, physiologists, and psychiatrists. So anything to say, sir?
Professor Apul.
So I think this is perfect. These are the steps actually which were discussed in various presentations also. This is how we proceed. So, and as just to highlight again, so although 50 milligrams have been used in various trials, but we rarely need to titrate till 50 milligrams. Usually 10 or 20 milligrams suffices in most patients.
Okay. Thank you, sir. So behavioral modification studies, we have already talked. Dr. Amita has discussed a lot about, okay, Dr. Amita.
The restriction of fluid, the patient is not taking a lot of fluids. So I told like on restriction, probably the Urine is going to be just concentrated, so it's not going to help. So it would be adequate volume in distributed form. That would be a better idea.
Okay,
rather
thank you very
than
much. Thank you.
restriction of the fluid.
Okay, thank you for correcting. Thank you. So this has been already talked a lot by Dr. Amita, so I'm not going in detail. So pelvic floor relaxation physical therapy. So this is essential component of the therapy. We all agree, yes, sir? So we have to maintain dietary charting and to look for the diet elimination diet. We all agree with this. So about guidelines also, they have strongly recommended for multimodal therapy, stress management, dietary advice, and physiotherapy. So what about oral therapies used in BPS? So in clinical practice, so which oral agents we are practicing, sir?
Dr. Shivam is around.
Yeah, so I think I personally am favor of amitriptyline. Amitriptyline works quite well in many of these patients. And then I add hydroxyzine in some of these patients. And if I think that there is something which is the problem is bladder centric, then I would also add pentosan polysulfate. So yeah, I think I would consider these three besides the pain management. Definitely pain would require anti-inflammatory analgesics in the latter fashion.
Okay, thank you, sir. So anything to say, sir, Dr. Taneja, sir?
No, I think this is fine. We must, as I said, in this particular patient, we would use alkalizing agent also.
Okay, thank you.
Because if there is something which is offending, we will need to go into the diet, we will need to go into the clinical examination to see if there is any, because if I suspect in young women like this who have only 3 to 4 times at night, but during the day they have 15, 16 times, that means there is an element of functional overlay, and that causes pelvic floor spasm. So pelvic floor relaxation physiotherapy, alkalizing agents, looking at the diet would become very essential for this particular patient. You can add clonazepam because it is going to be an anxiolytic. In addition, it is going to cause relaxation of the pelvic floor spasm. So that may help in this person.
Okay, thank you, sir.
Dr. Taneja, you missed muscle relaxant, your favorite tablet, one of them. If
Clonazepam is what is a muscle relaxant.
You usually say some many times, yes.
Okay, sir, thank you very much for the
information. I just want to mention one thing, that psychiatric evaluation should be the part of management, because this patient, like Dr. Taneja told, that weight loss is there. So one component could be GI problem or some kind of thing, but the other thing could be just depression. That could be the leading cause. So psychiatric evaluation, and then because many of the psychiatric medications have, kind of interactions with the medications of amitriptyline and gabapentin, then you have to decide those in collaboration with a psychiatrist. That is a very important thing in these kinds of patients.
So, sir, so whenever we are using amitriptyline, we have to know about its adverse effects and contraindications as well. So there are so many adverse effects, and whenever we are escalating the dose above 100 milligram, we should be really careful. And in cardiac patients, we should be really careful with this drug. We all agree with this. Yeah. So she followed up and she didn't have satisfactory response with amitriptyline, but had dry mouth and constipation. So what to do next? How to deal with this case?
Hello.
Yes, Doctor, you are taking? Yes.
Okay, Professor Shivam, please carry on.
Okay, thank you. So as I said, after amitriptyline, I might add in this patient hydroxyzine also. And then if the patient symptoms are bladder centric, I will add pentosan polysulfate. If the patient is not responding, then I might continue with intravesical installation. I have to think where to start doing a cystoscopy and a hydrodistension. If the symptoms are severe and they are quite prolonged, then I might now at this time do a cystoscopy and a therapeutic hydrodistension also.
So if we look at the literature, response rate of different therapies and different drugs, they are quite variable. So maybe it may be due to the heterogeneous group of population, maybe with there are different ways of evaluating as well. So amitriptyline does well. PPS, the results are really variable, as Dr. Taneja has already highlighted. And about hydroxyzine, it's mostly used in those with systemic allergy. So we went for, as she was not responding, so we went for cystoscopy with hydrodistension. And so we could see this type of picture during cystoscopy. Her bladder capacity was 500 ml at that time. So anything to say, sir? Taneja, sir?
Yes, so obviously what I have been trying to say is, hello?
Yes, sir.
Can you hear me? Yes, yes. So what I was trying to say that maybe she has something which is restricting the bladder rather.
Okay, we cannot hear. What is gone? So
we can't hear you.
So anything to say, sir? Dr. Apul, sir, anything to comment?
So because as we were anticipating, actually, her functional bladder capacity was small, 170 ml, but anatomically her bladder capacity is normal. And I can see typical glomerulations. Glomerulations are subcutaneous bleeding spots. So I can see numerous glomerulations in this patient. So I think the cystoscopy again goes in favor of our diagnosis of interstitial cystitis. And now that you have made, you have hydrodistended also, maybe this patient responds.
Okay. So how much long to distend? We have discussed a lot about this, and whether it's diagnostic or therapeutic, it doesn't matter. So short-term distension we all prefer in minutes. Though AUA has highlighted about distending for short duration, less than 10 minutes, I think we don't go for 10 minutes. Only 2 to 3 minutes is enough. I think we all agree with this. Yes, sir?
Yes, yes. Even the latest Campbell's urology, which came just this year,
yes, sir.
They also mention only 1 to 2 minutes.
Yes, sir. Thank you. So coming to outcomes of cystodistension, this has been highlighted by Dr. Sigdale. So I'm not going into detail. So it has good outcome at early follow-up, but for long-term follow-up, it has poor response rate. And on the thing to note that it doesn't appear to result in any long-term bladder dysfunction or decrease in capacity because of lack of randomization in studies. So I think grade A recommendation is still lacking. So all recommend this as grade C. So anything to say, sir, for this?
No, I think you have already mentioned everything.
Okay, thank you. So EAU guidelines, there's only weak recommendation for hydrodistension, we all know, because of lack of paucity of good studies, quality studies. So on follow-up, our symptoms got relieved significantly for 6 weeks, but gradually started deteriorating. So as we have already discussed, we can go for pentosan polysulfate. Yes, so this is AUA algorithm. So we start with the minimal invasive and go towards the most invasive, as Dr. Amita has already highlighted this, so I'm not going into the detail. So for this patient, she received capsule polypentosan sulfate 3 times a day and took for only 2 months because of high cost, but without any effect. Anything to say, sir? Dr. Shivam?
I think as this has been already said that pentosan sulfate will require at least around 3 months to show
that's a problem in this case.
Efficacy. So we can't say exactly whether this is working or not in this patient. Okay. So if she's not able to afford it, then we might have to think other ways like intravesical installation.
Oh, yeah. We went for intravesical installation of heparin and lidocaine.
The other thing I just want to say that we should combine the treatment. We must have started this pentosan at the time of hydrodistension itself, because this is a slow working drug. So till the time the effect of hydrodistension is waning off, you might get the effect of pentosan.
That's the point to take note, sir.
Yeah.
Thank you, Dr. Amita. So we need to combine these drugs because these are long acting. It takes time. So we need to combine this drug with another procedure that gives quick effect. So we all know about intravesical therapies for BPS. So there are many installations. So in clinical practice, which ones we are using? I'd like to ask Dr. Apul.
So intravesical therapy, let me clarify for intravesical therapy, the philosophy is that the disease is bladder centric. And unfortunately, many patients, they have disease, as you mentioned somewhere in your slides, is
Yes.
beyond also. So those components we are not tackling by focusing our therapy to intravesical therapies. So most of us, DMSO is not available in India, at least not in my part of the country. So intravesical pentosan sulfate again is not available. So actually we are just giving what the cocktail type of thing where we add some steroids, heparin, soda bicarb. So it's a cocktail that we give. So, but the problem is the compliance again. The patient has to come again and again. It's difficult for them often to get it done somewhere in their house or something. So this is usually, intravesical instillation therapies at least are, BCG should not be given. Regarding people have given triaminosolone, which is a steroid. Triamcinolone for intravesical injection instead of botulinum toxin. So this is relatively cheaper. So if you see a Hunner lesion, you can inject, triamcinolone, and this will, it's there written injection of triamcinolone also there. It's a recommendation. So especially in patients, it works, especially in patients who have Hunner's lesion. So and botulinum and all these options are of course there. Cyclosporin, mostly it's given orally, but yes, intravesical therapy can also be given. I have no experience with all these with cyclosporin either orally or intravesically.
So I think no one has experience with cyclosporin and other drugs maybe. So I think nice information from Dr. Apul. So still intravesical therapies are weekly recommended by EAU guidelines, but still we are using it with good short-term effect.
One thing I want to state that, if there is a problem of poor compliance, patients are coming from distant places, I started making them learn to do self-installation.
Yeah.
I've seen in different part of world also they are relying upon self-installation. So that can be done and patients are very good in doing that. So that could be arranged for those patients.
Yes, that's a good point to note. So also, say at mild resolution of symptoms increase after stopping the therapy, as we all know, we know that. Received another hydrodistension. Same thing. So what next we can do? We all Dr. Apul has already highlighted. We can go for botulinum injection, and further on. So anything to comment, Dr. Amita? For failed therapy.
Yeah, so regarding the botulinum toxin injection, I think all other panelists will agree that personally we have not seen very good effect. Even if at all any effect is there, it is not long lasting. But anyway, we can have the trial of botulinum toxin before thinking of higher treatments, and I always combine treatments. So I have seen that there is always a good response on combining 2-3 treatments together. So usually we never get patients beyond intravesical installation, very advanced stage ulnar disease or something which is requiring a kind of surgical management is very rare. Hardly in 2-3 patients in 100 patients might require these kinds of therapies.
Okay, thank you very much. So
I need to make one point here. So we have tried everything. We have done hydrodistension. It is not working. Oral PPS is not working. Amitriptyline is not working. So there is a thing that we are missing. We are missing a diagnosis. We should revisit our diagnosis. Just because we are at the interstitial cystitis webinar, we should not forget that there could be something else which is pushing. I will repeat a transvaginal ultrasound for the pelvic organs. This is the time to look at something there. I would also get HSV, herpes simplex virus, which at this young age is very important. So IgG and IgM for herpes simplex virus, because I have personally found young ladies like this who will present with non-specific pain with frequency. You, you, when you do a cystoscopy, the bladder is distending nicely, but when you do the HSV, you hit the target, you apply acyclovir cream locally and you give acyclovir orally after that, and they improve. So we are missing out on something which is very important. We at this point, when you've done 2 hydrodistensions, you've treated everything, relook the diagnosis. That is the
Thank you,
message I
sir.
wanted
So
to say.
whenever the patient is not improving, we need to revisit our diagnosis. So that's the clinical principle that also applies in BPS. So should we move to BPS and pregnancy? It has been already covered by Dr. Amita, so I am not going in detail. There is scanty evidence. So triptyline and heparin are the only safe drugs considered in pregnancy, and PPS, it is well studied in animals but not used in human beings. So anything to comment on this PPS in pregnancy? I think we have nothing to comment on because there's still lack of controlled trials in human beings.
So I will tell you that my patients who have been on follow-up, they became absolutely fine for almost a 2-year period around the pregnancy, but they came back with symptoms after 2 years of delivery, and that's why when there is a pregnancy, you don't really need to give anything.
Okay. Thank you, sir. So should we move on to next case or?
I think
no. I think we'll need to stop here because we have already overshot.
Okay.
Dr. Sujit, you have done a wonderful job moderating this session, and I'm sure that people who are still logged in would have benefited a lot. If they have any more queries, they can simply send an email to any of us and we'll be very happy to answer. And I must thank Dr. Pawan Chalise, without whose cooperation this webinar could not have been conceived. And of course, my so learned panel, starting from Professor Shivam, Professor Rapul, and Dr. Amita Jain, and the colleagues from Nepal. They have been wonderful. I'm so happy to know that a good work is being done, because when we started this movement in 2016, Amita Jain would remember, I met her and I said, look, we need to do something in this part. She would remember our first meeting. I just picked it up from somewhere and called her and said, let us meet and do. This is what has the result. The result is this webinar with so many people still logged in, 72 people still at the present moment at 8 p.m. Thank you, everyone. Thank you, Swati Spentos, for taking the lead. Thank you, Deepti and Cheshta, for your untiring efforts. We could depend upon you, and we have, and you've done a wonderful job. Dr. Pawan Chalise, please, can you add on something to which I may have missed?
Yes, thank you, Dr. Rajesh, for giving this opportunity to be linked with your society. And I'm sure in Nepal, as we are discussing that, where urology is now budding, and now it's already been a big tree. So we need to have this kind of fruits in our trees, like this kind of disease, which has really has some kind of orphan disease or some neglected part of this in our society. Although we have lots of prevalence, still we have high prevalence of this disease in our society, and we need to educate ourselves, our urogynecologist colleague, our psychiatrist, and it's all a team reports, because today we have learned a lot from your side. And I think I'm very much sorry to Dr. Sujit that he is well prepared. He has 2 cases, and I think second case we have to discuss in some other forums, and we have to get that time in the future. Thank you very much
Yes.
for. I especially would like to thank the faculties from NOWS and all your team efforts and the faculties from GIBS to be here in this platform, and there are lots of good response from all over the world, and think we need to continue this in our future days too. Thank you, Dr.
Dr. Sanjay
Rajesh.
Pandey had to leave for an emergency. So on his behalf also, I will convey thanks to the organizers of the webinar.
Yeah, and
Thank you
also
all.
thanks
Have a,
to and also thanks to Deepti and her technical team and the Swati Spentos Private Limited, who gave this platform to have this discussion, and without their support it had not been possible. So
So have a nice evening, all of you. Enjoy. Have a
thank
nice
you.
time.
Stay safe, because
Bye-bye.
this is a hard time for all of us, and thank you.
Thank you, Dr. Pawan, Dr. Rajesh, Swati. Thank you. Thank you.
Professor.
Thank you all for this
Thanks.
session. Thank you very much.